When I got this topic, I was thinking, what does HbA1c has to do with this Carmelo symposium? But as I went through the literature and I've completed my presentation, I realized that interpreting the HbA1c has got a lot to do with the Carmelo. So diabetes complications without elevated HbA1c, is it a myth or reality? So I will be discussing with special reference to the Indian population. So diabetes, as you know, is a chronic metabolic disorder marked by hyperglycemia and leading to end organ damage. The DCCT and the UKPDS have established HbA1c as a key marker, as we know. But several clinical observations challenge the sufficiency of HbA1c. The development of retinopathy in individuals who have HbA1c less than 7, the presence of neuropathy in prediabetes, the cardiovascular events in well-controlled diabetics, and discordance between HbA1c and the CGM metrics. What is the biological basis of HbA1c and its predictive strength? As you know, HbA1c forms a non-enzymatic glycation of hemoglobin A at the N-terminal valine of the beta chain. It reflects the weighted mean plasma glucose over an average of 8 to 12 weeks. The strengths include it has got strong epidemiological correlation with the microvascular complication, standardization, which is very important through the NGSP and the IFCC systems, convenience and low biological variability, but it represents mean glucose only, in no information about the glycemic excursion and about the fasting and postprandial levels, and no insight into hypoglycemia. So it is an average metric that can mask the extremes. And we have the epidemiological burden of diabetes in India, which is rising every day. And there are care continuum gaps. So this is based on the Lancet Global Health, which demonstrated that there is lack of awareness. The amount of the number of patients with controlled HbA1c is very less, and despite having diabetes, the number of patients using lipid lowering therapy is very less, which means that more patients can end up in complications. Coming to the microvascular complication despite target HbA1c, coming to retinopathy. Retinopathy has been documented in pre-diabetes, early diabetes, and patients with HbA1c below the therapeutic targets. The mechanisms include capillary basement membrane thickening, pericyte loss, oxidative stress, and the polyol pathway activation. And the retinal microvascular damage may begin before the sustained elevation of mean glycemia. And you can see the national prevalence is around 12.5%, and the vision-threatening diabetic retinopathy accounts for 4%. So DR was present even among patients with modest HbA1c levels, emphasizing duration and variability contributions. Coming to diabetic kidney disease, which was alluded to in the previous lecture, microalbuminuria, you know that it correlates with glycemic variability, the blood pressure load, the RAS activation, and the endothelial dysfunction. And studies demonstrate hyperfiltration associated with postprandial spikes independent of HbA1c. Neuropathy in prediabetes is well documented. It suggests early microvascular ischemia and mitochondrial dysfunction. The mechanisms include sorbitol accumulation, oxidative stress, microvascular ischemia, and protein kinase C activation. And mean glycemia may underestimate the neuronal metabolic stress. Coming to the macrovascular complications, cardiovascular disease doesn't arise alone from diabetes. There are other factors like dyslipidemia, insulin resistance, endothelial dysfunction, chronic inflammation, and the glycemic excursion. HbA1c reduction alone yields modest macrovascular benefit compared to the multifactorial risk reduction. This was seen in the landmark trials. So you know the ticking clock hypothesis, which was taken from the UKPDS. We have another article which was published in JACC a couple of years ago, which added more evidence to that. The original ticking clock hypothesis proposed that cardiovascular disease in diabetes begins long before diabetes is clinically diagnosed, and the UKPDS showed that many patients already had evidence of macrovascular disease at diagnosis. The risk of MI increased progressively with rising HbA1c, and the exposure and vascular injury is likely to begin 10 to 15 years before the diagnosis, and post-trial follow-up demonstrated the legacy effect, which means that early glycemic control is very important. And this is the modern confirmation by the 2024 JAC registry data, which had, you can see more than 127,000 individuals with type 2 diabetes. And this showed that individuals who later developed type 2 diabetes had twofold higher prevalence of CVD events up to 30 years before the diabetes diagnosis, and this elevated odds ratio was seen 25 to 30 years before diagnosis, increasing steadily towards the time of diagnosis, and post-diagnosis CVD risk remained significantly elevated. Why this is important? And this moves the hypothesis from the epidemiologic modeling to the population level longitudinal proof. And it predicts that cardiovascular risk precedes diabetes by decades. Diabetes may represent a late metabolic marker of an already established atherogenic process, and hyperglycemia is not the starting point. It's just a milestone in an ongoing cardiometabolic trajectory. So this is the integrated pathophysiological model. The vascular clock likely begins with insulin resistance, the atherogenic dyslipidemia, the low-grade inflammation, the endothelial dysfunction, and these processes can occur in prediabetes with visceral adiposity, the metabolic syndrome, and the MASLD, which you all know. And hyperglycemia is often the final visible marker, not the initiating factor. So what are the clinical implications? The old model meant that we treat glucose after diagnosis. The ticking clock model tells that cardiovascular risk management must begin at the prediabetes stage, at the metabolic syndrome stage, at the first evidence of insulin resistance. So what are the practical actions? Early ASCVD stratification, early statin therapy, aggressive BP control, weight-centric therapy, early use of drugs like GLP-1RA and SGLT2 inhibitors, screening in high-risk individuals before the glycemic thresholds are crossed. And this is exactly what the previous speaker was mentioning too. In the South Asian context, it is very important. We have earlier onset of diabetes, higher visceral fat, severe atherogenic dyslipidemia, higher small dense LDL, and early endothelial dysfunction. So this is the unified take-home statement. Wikipedia suggested that the clock was ticking at the diagnosis. JAC registry proves that the clock had already been ticking before decades. So some mechanistic insights into what is happening. This is a glycemic variability where the fluctuations activate NADPH oxidase, the NF-beta pathways, the inflammatory cytokines, and the endothelial apoptosis. And this can happen even when the HbA1c is less than 7. Postprandial hyperglycemia has always been known to be a critical component of the endothelial dysfunction, and these excursions are not proportionately reflected in the HbA1c. The metabolic memory, epigenetic modifications persist even after the hyperglycemia normalization. This is because of the histone methylation, the DNA methylation, and the persistent mitochondrial dysfunction. There are non-glycemic drivers which worsen the complications like hypertension, the LDL cholesterol, adiposity, which we have already discussed, and these act synergistically with the hyperglycemia. There are limitations of HbA1c in the Indian population. There was a very recent article which was published in the Lancet, and which is very much popular, and it has been cited by most of the national media, which is authored by none other than Dr. Shashank Joshi and Dr. Anup Mishra and Dr. Samajsdar, which looks at the fallacies of HbA1c in Indian population. And see that the paper showed that hemoglobinopathies are very prevalent in India, and these can affect the glycation kinetics and the assay interpretation. And iron deficiency anemia, which is again highly relevant in the Indian population, this again can affect the RBC lifespan and the HbA1c values. This is probably one of the biggest issues with the use of HbA1c in Indian setup, the lack of standardization. This lack of standardization impacts the diagnostic accuracy, leading to potential misclassification of diabetes patients. And the major concern is the widespread use of non-NGSP certified methods. The paper which I quoted, it recommends a comprehensive approach, including mandatory participation in external quality assurance programs, promoting NGSP certified devices, and implementing robust training programs for laboratory technicians. So the misclassification risks are very high. Individuals with diabetes may be falsely identified as healthy, delaying intervention, or healthy individuals may be misdiagnosed, leading to unnecessary anxiety. So alternative markers are there. You can use the CGM for the time in range. There are glycemic variability indices, and there are methods for detection of asymptomatic hyperglycemia. We know that TIR again correlates with the complication risk. Fructosamine and glycated albumin has been there for quite some time. They are useful in specific settings. Again, 1,5 anhydroglucitol is again it reflects the recent glycemic excursion. Again, these are limited by the routine availability and lack of standardization. There are rural and urban healthcare disparities. In the rural India, we have higher undiagnosed diabetes, limited HbA1c access, and delayed complication detection. Whereas in urban India, we have better monitoring tools and higher early onset disease due to lifestyle factors. Still, the diagnosis and the diagnosis rate remains low, and the complication rates remain high. So what are the clinical implications? HbA1c should not be interpreted in isolation. It must include glycemic variability, the postprandial glucose, the blood pressure, lipid profile, renal function, duration of the disease, and also don't forget about the hematological status of the patient. So this is a proposed multi-dimensional risk model. You have to look at the mean HbA1c. It is still important, but you also have to look at the time in range, the glycemic variability, the postprandial spike, the cardiometabolic profile, the duration, and the hematologic modifiers and the screen. Expand the CGM access, strengthen the rural screening programs, integrate anemia screening with diabetes evaluation. Just like when we do a UACR, you have to check for the urine routine. A patient can have a false positive UACR if the patient is having an infection or a fever. So simply doing a UACR without a backup routine urine can misinterpret the diagnosis. So the same can happen with an HbA1c. And develop Indian specific risk calculators. Future research directions, prospective cohort studies are required. Epigenetic studies in South Asians, we have studies, but we still require many studies. Standardization is again a big ask, and evaluation for multi-parametric screening with algorithms is very important. So this answers the question, the myth versus reality. Complications without HbA1c are biologically plausible, epidemiologically observed, mechanistically supported, and clinically encountered. So therefore, the phenomenon is not a myth, and it is a measurable reality which answers the question which I put forward. So coming to the conclusion, HbA1c remains an indispensable but insufficient as a solitary predictor of complication risk, particularly in the Indian population. Biological, methodological, and healthcare system factors necessitate a broader multidimensional approach. And the Lancet paper, which I showed, it strengthens the argument that diabetes care must transition from HbA1c centric to the metabolic risk centric evaluation. And only such a paradigm shift can meaningfully reduce the complication burden in the world's largest diabetes population. So thank you for